Hi, I'm Dr. Shishir Agrawal from Apollo Medics Hospital, Lucknow. Today we'll presenting a class on supraclavicular brachial plexus block. As we know, supraclavicular block is the most common regional anesthesia technique after the the supraclavicular block is the most common regional anesthesia technique after the central unilateral block. Almost 15% of all the regional block. This block is very popular because it is very simple to give and efficacy is very high. The four things this make this block very simple. This block is very superficial. These supraclavicular nerves are very superficial. They are around 1.5 to 2 centimeters from the skin. They are closely clustered, so they are very easy target. Success rate is high. Close to this nerve is a very good landmark, which is subclavian artery, which can be felt, visualized, or can be assessed in Doppler as well. There is a very good structure that is first rib, which protects from the pneumothorax. It acts as a shield. Success rate of this block is around 85 to 95%. As we all know, when we give any block closer to ventral rami in the neck, it is intestinal block. But here in supraclavicular block, we target trunks and division at the level of supraclavicular fossa. History of this block is very interesting. In 1928, Cullen campaign, he gave first supraclavicular block. He gave this block in sitting position. So suddenly this block became very popular. But it was associated with risk of pneumothorax. So people started looking for another alternative technique. After some time, additionally, he discovered another technique, which is axillary nerve block. And then after that, popularity of supraclavicular nerve block it decreased. In 1978, Lagrange he used ultrasound for regional anesthesia technique. He identified subclavian artery in supraclavicular block and he gave supraclavicular block. At that time, the image of ultrasound machine was not very good to identify supraclavicular brachial plexus. First paper, ultrasound guided supraclavicular approach for regional anesthesia of the brachial plexus was published in 1994 by Stephen Kaplan. So this block can be given for all upper extremity, including shoulder surgery. But for shoulder surgeries, we require relatively higher volume. Most common indication of this block is elbow surgery, hand surgery, and mid-humeral surgeries. Right from axillary nerve, radial nerve, all the other brachial plexus element, they all are blocked. But to block suprascapular nerve, we require high volume because this nerve is lying relatively away from the side where we inject. Patient refusal is the utmost contraindication of any block. But we should avoid this block in those patients who having ipsilateral neural injury or in those patients who cannot afford diaphragmatic palsy, like patient with pulmonary disease, contralateral phrenic palsy, or the pneumothorax. So this supraclavicular brachial plexus lying posterior to the clavicle above the first rib. Just a quick revision of the brachial plexus anatomy. C5 and C6 ventral lemma forms the upper trunk. C7 ventral lemma forms the middle trunk. C8 and T1 ventral lemma they forms the C8 T root T1 root forms the lower trunk. They again divide in anterior and posterior divisions. Posterior divisions of all the trunks they forms the posterior cord, while the anterior division of the upper trunk and middle trunk it forms the lateral cord. The anterior division of the lower cord it continues as the medial cord. So this brachial plexus it lies posterior and posterior lateral to the subclavian artery between the anterior and middle screening muscle just over the first rib. Subclavian vein it is anterior to the scalenus anterior muscle. You can appreciate there are so many arteries like dorsal scapular artery, transverse cervical artery, and suprascapular artery, which may come into the field while we are giving this block. So this is the cadaveric dissection of the part. So really, is there really any brachial plexus sheet? So for this, Philip B. Cornish, he did a study in 2006, and according to him, there is nothing like brachial plexus sheet. This brachial plexus is lying in the tissue plane, similar to sciatic nerve. Side effect of supraclavicular brachial plexus block. Phrenic nerve palsy is very common, around 40 to 67%. Risk of Horner syndrome like anhidrosis, meiosis, and ptosis, it risk is around 1%. Recurrent laryngeal nerve palsy is relatively common on right side compared to left side. This is relatively vascular structure, so chances of arterial puncture is there. Risk of nerve injury is very rare. Risk of permanent nerve injury is 1 into 1000 to 1 in 5000. Risk of pneumothorax is still there even if you are using the ultrasound guided block. The risk of pneumothorax while using ultrasound guided supraclavicular brachial plexus block is 1 in 4000. And always there is risk of last while we give any regional anesthesia technique. Anuj Bhatia, he published a case report of pneumothorax after ultrasound-guided supraclavicular brachial plexus block. Bhuvi Hong, he published his study in 2021. And he found that incidence of hemidiaphragmatic palsy is around 47.5% with the ultrasound-guided supraclavicular brachial plexus block compared to costoclavicular brachial plexus block, where the incidence is around 11.4%. Fredrickson et al. He did a study speed of onset of corner pocket supraclavicular and infraclavicular ultrasound-guided brachial plexus block, and he found that still there is a risk of failure 30% for the ulnar nerve. So total 30%, 30 patients were included in supraclavicular group and 30 patients were included in infraclavicular group. And failure to block ulnar nerve was around 11 out of 30 patients. risk factor for failure. Shinzo Abe, he did a study which was published in 2023, and the author concluded that risk of failure is high in patients where this block is given for elbow surgery, in those patients who are very obese, or where systemic blood pressure is more than 170 millimeter of mercury. So there are some anatomical variations which affects drug spread and may be a cause of failure. Sometimes there are ligament of Chakrkand which separates inferior trunks, uh, inferior and middle trunk from the superior trunks. Might affect drug spread. At this level, there are so many trunks and the divisions. So there are epinurum of the trunks and division which might affect the drug spread. In this study, this Brazilian study, author found inferior trunk which is anterior to the subclavian artery. Equipment is common. We require a high frequency probe at 22 gauge 5 centimeter blunt tip needle. Depending upon your practice, you might require peripheral nerve stimulator. For daycare surgeries, we take 25 to 30 ml of xalocaine adding 2%. But for the longer duration of surgery or for the post-operative analgesia, we usually take 20 ml of the 0.75% bupivacaine or 0.5% bupivacaine. Depending upon your practice, you can use mixture of Jolly with ADR with the longer acting local anesthesia drugs. So what are the optimal volume for this block? Duggan studies in 2009 and he found that AV50 for this block is 23 ml and AV95 is 42 ml. It means 5% of the patient, they require higher volume than the 42 ml, around somewhere around 50 ml. Frank Gang, he published his article and he took a 0.275% of the ropivacaine. MEV 90 was 30.2 ml. MEV 95 was 31.1 ml. Total 88 milligram of the ropivacaine, average 88 milligram of the ropivacaine was required. Again, Lin Wu, he studied the concentration of the effective ropivacaine to block supraclavicular block, and it was a systemic review which was published in 2023. So he compared 0.5% ropivacaine, 0.75% ropivacaine, and 1% ropivacaine. Duration of analgesia was similar in all the three groups, but the onset was faster in 0.75% ropivacaine group compared to 0.5% ropivacaine. In another study, which published in October 2023, author found that EV95 for 0.5% ropivacaine was around 32 ml. To give supraclavicular brachial plexus block, patient should be head up position. Head and neck should be rotated on the contralateral side. A roll should be placed under the shoulder. Arm should be pulled down and arm should be besides the patient, and hand should be rested upon the abdomen. Alternatively, we can use lateral position. Block performer should be on the head end and ultrasound machine should be in front of. Now coming to the technique. Before giving final injection, we should do a dynamic scan. So we should look for all the elements of the brachial plexus, all the nerve roots 5, 6, 7, 8 and T1. Posterior border of sternocleidomastoid should be marked. Imaginary line of interscleral groove should be marked or it should be imagined. Brachial plexus element will be lying between the interscleral groove. Ultrasound probe should be placed in supraclavicular fossa parallel to the clavicle, and then probe should be manipulated or it should be tilted in that way that when this subclavian artery it looks a round hypoechoic structure, and all the brachial plexus element it lie on the rib because it will minimize risk of pleural injury. The probe should be tilted slightly anteriorly. Now coming to the dynamic scan, we should start looking from all element started from C5. C5 है relatively blunt, smaller anterior and posterior tubercle. There is a muscle. There is this muscle. This is longus musculi and longus capitis. Then at the level of C6, anterior tubercle is very prominent and longus capitis muscle is not there. Then there is a C7 where there is only a posterior tubercle is found and vertebral artery pulsation may find. When we go further down, C8 element is lying over the rib and T1 element, T1 nerve root, it's coming from the behind the rib or lie over the pleura and join to form C8 to form inferior trunk. Now coming to procedure. Identify subclavian artery, superior trunk, middle trunk, inferior trunk. First rib, which is hyperechoic, with this is hyperechoic pleura, which it is shimmering structure. After a scan, we can find the dorsal scapular artery. We should avoid this artery. We should usually put the color Doppler to look for this artery or any other artery. Then needle should coming from the lateral to the medial or posterior to anterior. This is the inferior trunk, middle trunk. We should target between the inferior trunk and the middle trunk. When we inject here, it is corner pocket, but here we are targeting between the inferior trunk and middle trunk, and we will deposit 10 ml of the local anesthesia drug here. After gentle aspiration, should deposit 10 ml of the local anesthetic between inferior trunk and the middle trunk. Second injection should be done between the superior trunk and middle trunk. Okay, look for the drug spread. It is covering inferior trunk and middle trunk. Second injection between the superior trunk and the inferior trunk element. So, almost all the elements are bathed. Now, in 2017, Anna Herrera, he published his paper and he gave an alternative block technique. He used this technique from middle to lateral or from anterior to posterior. And what he found, what the author found was that this middle supraclavicular approach is an effective alternative of the conventional lateral to medial technique. Q. Strong, he published his study in RAPM article in 2009, where he compared double injection technique with the single injection technique. And he found that the double injection technique is not superior to the single injection technique. Me Guillaume Lee, he gave intracluster supraclavicular block, and he found that success rate is quite high, around 92.2%. Yamin Zhou, he published his study in Korean Journal of Anesthesiology in 2021. So he compared two groups. One is the intertruncal group between the lower trunk and middle trunk. Another group is the corner pocket, conventional corner pocket group, and he compared ulnar blockage. And he found that in intertruncal group, chances to block ulnar nerve was relatively higher compared to the corner pocket injection technique. Dr. Sandeep Diwan, he published his study and he gave injection at the level of middle trunk. Only 7.5 ml drug was, he found that it is effective enough to block this whole supraclavicular brachial plexus. And he named this block as a middle trunk block. Oroz Siddiqui, it is a very important article published in RPM in 2019. So author did a histological study of the brachial plexus element and he found that there are adipose tissue, it lies between the superior trunk, and inferior trunk. This adipose tissue, it facilitates drug deposition and drug spread. So author, he gave first injection between superior trunk and middle trunk, second injection between middle trunk and lower trunk. And he found that there is a lesser risk of pneumothorax and vascular injury because we are quite away from the dura and quite away from the subclavian artery. As the inferior trunk is lesser visualized, it is poorly visualized under ultrasound beam. So during corner pocket injection, there is a high risk of neural injury. But with this approach, we may minimize this neural injury risk of inferior trunk. We are giving more superficial block compared to corner pocket injection. So these structures are better visualized. Dr. Shivashangunam, he published his article in RFPM, a randomized comparison of extrafacial versus subfacial injection of local anesthesia during ultrasound-guided supraclavicular brachial plexus block. And Dr. Shiva, he found that time to onset and duration of analgesia was superior with this subfacial block technique. Onset of block was around 7 minutes compared to 20 minutes with the conventional technique. So some important tricks: we should never advance our needle until unless whole of the needle is visualized. Uh, As we saw, lot many arteries in the brachial plexus, basically in supraclavicular region. Always put color Doppler before giving your injection, before inserting your needle. Take a smaller needle because with the longer needle, there is a higher risk of pleural puncture. We should not give injection superficial to the upper tract because drug will spread more cephalic and higher risk will of phrenic nerve palsy is there. Sometimes suprascapular nerve it comes into the field, so we should avoid injection or piercing of suprascapular nerve because it may lead to uh, supraspinatus and infraspinatus palsy. Do not give your injection while you are facing the high pressure during the injection. Thank you very much for listening me. I hope all the important elements of the supraclavicular brachial plexus block is covered now. Thank you.